Welcome to Studious, your partner for high-yield board examination preparation. Today, we are building the complete surgeon's blueprint for wound care and healing biology. This topic appears across every major licensing examination: USMLE Step 1, Step 2, and Step 3, MRCP, PLAB, AMC, and MBBS finals, because it sits at the exact intersection where basic science meets clinical decision-making. Examiners do not test wound care in isolation. They test your ability to move along a clinical chain. First, assess the wound mechanism, then understand the underlying healing biology, then stratify the infection risk, then choose the correct strategy for closure, then anticipate complications, and finally deploy the right therapeutic adjuncts. Every one of those links in the chain is a potential exam question. What you will build in this video is not a list of facts to memorize. It is a thinking framework that will allow you to approach any wound-related clinical scenario with confidence. We will cover the 6 types of traumatic wounds and their infection profiles, the overlapping cellular phases of healing, the tensile strength curve, the 4-tier surgical classification system, the 3 types of healing by intention, suture timing, pathologic scarring, the diabetic foot as a clinical synthesis model, and the 4 major therapeutic adjuncts, including negative pressure wound therapy and hyperbaric oxygen. Every concept connects directly to board examination questions. Let us build the blueprint. Before we examine individual topics, let us establish the overarching mental model that will organize everything in this video. Managing any wound, whether in trauma, surgery, or chronic care, requires progressing through 6 sequential steps, and examiners test each of these steps independently. Step 1 is to assess the mechanism. The way a wound was created determines its tissue characteristics, contamination level, and infection risk. A puncture wound behaves completely differently from an abrasion, and your initial management must reflect that difference. Step 2 is to understand the biology. The phases of wound healing, coagulation, inflammation, proliferation, and remodeling, are not just theoretical constructs. They are the biological basis for every clinical decision you will make, from when to change a dressing to why a diabetic patient cannot heal a pressure ulcer. Step 3 is to stratify the risk using the standardized surgical wound classification system. Step 4 is to execute the correct closure strategy, choosing between primary, secondary, and tertiary intention based on the wound's contamination level and time since injury. Step 5 is to anticipate complications, dehiscence, abnormal scarring, and the systemic factors that impair healing. Step 6 is to deploy the appropriate therapeutics, from antibiotic stewardship to negative pressure wound therapy to tetanus prophylaxis. This framework is your diagnostic and therapeutic roadmap. Commit it to memory, and wound care questions will become one of your highest scoring areas.
The first step in wound management is assessing the mechanism, because mechanism determines tissue damage pattern, contamination level, and infection risk, all of which drive your initial management decisions. There are 6 wound types you must know cold. Abrasions result from shearing blunt force scraping away the epidermis. They carry a risk of ground-in dirt causing traumatic tattooing, permanent pigmentation from embedded particles, so meticulous cleaning is essential. The wound pattern also gives clues to the direction of force, which is forensically significant. Contusions are closed injuries, where blunt force disrupts superficial vessels with the skin remaining intact. Infection risk is low. A critical exam pearl: you cannot reliably estimate the age of a bruise by color alone. However, a yellow bruise, caused by biliverdin converting to bilirubin, is a reliable indicator that the injury is at minimum 18 hours old, and this is specifically tested on examinations. Lacerations are caused by blunt force tearing or crushing. They have irregular, devitalized margins with high infection risk, and almost always require debridement before closure. Incisions are clean, sharp-edged cuts with minimal surrounding tissue damage, low infection risk. The largest dimension documented is surface length, not depth. Puncture wounds have a deceptively small surface entry with deep tract penetration, carrying an extremely high infection risk. The deep tract becomes anaerobic rapidly, creating ideal conditions for clostridial infection and tetanus. Avulsions involve tearing away a tissue flap with severely compromised blood supply, requiring urgent viability assessment.
Understanding the biology of wound healing is one of the most consistently tested areas in basic science examinations. The key conceptual point, which most students miss, is that wound healing phases are not sequential steps that switch on and off. They are overlapping biological processes that occur simultaneously on a continuous timeline. Immediately at the moment of injury, coagulation begins. Platelets aggregate at the wound site and release two critically important growth factors: platelet-derived growth factor, abbreviated PDGF, and transforming growth factor beta, abbreviated TGF-beta. These are the primary recruitment signals that initiate the entire healing cascade. Within hours of injury, the inflammatory phase is established. Clinically, this appears as the cardinal signs: erythema, heat, swelling, and pain. At the cellular level, polymorphonuclear neutrophils, or PMNs, are the first responders, arriving in greatest numbers at 24 hours post-injury. Macrophages arrive later, peaking at 48 hours. Macrophages are arguably the most important cells in wound healing. They clear cellular debris and devitalize tissue, present antigens, and release the growth factors that drive the next phase. From days 3 to 14, the proliferative phase begins. Fibroblasts migrate in and synthesize new collagen matrix. Simultaneously, vascular endothelial growth factor, VEGF, drives angiogenesis, the formation of new capillary networks. The clinical hallmark of this phase is granulation tissue, the beefy red, moist, granular surface visible in healing open wounds. Epithelialization, restoration of the basement membrane via type 4 collagen, begins early and continues through this phase. Finally, contraction and remodeling by myofibroblasts and collagen cross-linking continue for weeks to 2 years. Two further concepts from wound biology are heavily tested and deserve dedicated attention. The first is the 48-hour cellular clock, which encodes the most frequently examined cellular timing facts. At 24 hours post-injury, polymorphonuclear neutrophil infiltration reaches its peak. These cells perform the critical early function of killing bacteria through oxidative burst mechanisms, a process that is strictly oxygen-dependent, which we will return to when discussing complications. At 48 hours, macrophage infiltration peaks. This timing is crucial because macrophages are the essential bridge between the inflammatory and proliferative phases. An experiment from the 1970s demonstrated that macrophage-depleted wounds show dramatically impaired healing, confirming that the macrophage is not simply a debris clearer, but the indispensable coordinator of the proliferative response. The second concept is the biochemical dependency triangle for collagen synthesis. Collagen is the dominant structural protein of healed tissue, and its proper formation requires a specific enzymatic hydroxylation step acting on proline and lysine residues to create the stable triple helix molecular structure. 3 cofactors are absolutely required for this hydroxylation reaction: vitamin C, also known as ascorbate, iron, and alpha-ketoglutarate. The board pearl that flows from this biochemistry is one of the most reliable exam questions in medicine. Scurvy, which is vitamin C deficiency, presents clinically with poor wound healing and gingival bleeding, both directly explained by the fact that underhydroxylated collagen cannot form a stable triple helix and therefore lacks structural integrity. This is not a trivia question, it is applied biochemistry. The biochemistry of collagen synthesis translates directly into the mechanical behavior of healing wounds over time, and understanding the tensile strength curve is essential for both examination success and clinical practice. Immediately after injury and wound closure, tensile strength is essentially zero. The wound is held together only by sutures or the clot. Over the first week, as initial collagen deposition begins, tensile strength rises to roughly 20% of native tissue strength. By 1 month, as collagen cross-linking proceeds and the matrix matures, strength reaches approximately 60%. The most important milestone on this curve occurs at 3 months post-injury, This is when maximum tensile strength is achieved and the wound plateaus at roughly 70 to 80% of the original uninjured tissue strength. Here is the high-yield exam point that is tested repeatedly. A healed wound never fully recovers 100% of its native tissue strength. The maximum possible is 70 to 80%, achieved at 3 months, and this plateau is permanent. This has profound surgical implications. It means that fascial closures from previous abdominal operations have permanently reduced load-bearing capacity compared to native fascia, explaining why incisional hernia risk exists throughout a patient's lifetime after laparotomy. It also means that a patient who asks when their wound will be fully healed needs to understand that the biological answer is 3 months for maximum strength, and that the recovered strength will be slightly less than the original. Commit the numbers: 3 months, 70 to 80%. This combination appears on board examinations worldwide.
Risk stratification is the third step in the wound management framework, and the standardized surgical wound classification system is one of the most universally adopted and broad-tested tools in surgery. The system divides all surgical wounds into 4 categories based on the degree of microbial contamination at the time of surgery, with each category carrying a specific expected surgical site infection rate. Class 1, clean, carries a 2% infection risk. These wounds are created under strict aseptic conditions, with no entry into the respiratory, alimentary, genital, or urinary tracts, and no evidence of local inflammation. Elective hernia repair and breast lumpectomy are classic examples. Class 2, clean contaminated, carries a 5% infection risk. These wounds involve controlled entry into one of the hollow tracts, bowel, biliary system, or genitourinary tract, under controlled conditions without significant spillage or pre-existing local infection. Elective cholecystectomy or planned bowel resection fall into this category. Class 3, contaminated, carries a 15% infection risk. This includes gross gastrointestinal spillage, entry into an infected biliary or genitourinary tract, recent traumatic wounds, or a major breach of sterile technique during surgery. Class 4, dirty or infected, carries a 35% infection risk. This category covers wounds with pre-existing purulence, perforated viscera, gangrenous appendix, or established fecal contamination from remote trauma. This classification directly drives antibiotic prophylaxis decisions and the choice of wound closure strategy, creating a bridge between risk assessment and clinical management.
Step 4 in the wound management framework is choosing the correct closure strategy, governed by the 3 types of healing by intention. This is one of the most frequently tested concepts in surgical board examinations, and the distinction between all 3 must be precise. Primary intention, also called first intention, is used for clean wounds with minimal tissue loss and low infection risk. The wound edges are directly approximated and closed, with sutures, staples, skin glue, or adhesive strips. For traumatic wounds, the 6 to 8 hour window after injury is the classical time limit for primary closure. Beyond this window, bacterial counts in the wound exceed safe thresholds. In clean surgical incisions, primary closure is immediate. Epithelialization under primary closure is complete within 24 to 48 hours, at which point the occlusive dressing can safely be removed. Secondary intention is used when the wound cannot be closed, typically due to excessive tissue loss, heavy contamination, or ongoing infection. The wound is left entirely open and fills in from the base upward through granulation tissue formation. Wound contraction by myofibroblasts proceeds centripetally, inward from all edges simultaneously. Epithelialization advances across the granulation tissue surface at a precise rate of 1 millimeter per day. No sutures are used. Third intention, also called delayed primary closure, is a 2-stage strategy. The wound is initially left open for 3 to 5 days to allow bioburden clearance and early granulation tissue formation. Once the wound is clean and bacterial counts have fallen, formal surgical closure is performed. This approach is ideal for contaminated traumatic wounds and Class 3 surgical wounds. Remembering the 1 millimeter per day epithelialization rate for secondary intention is a guaranteed board examination answer.
The practical execution of primary wound closure requires knowledge of suture material selection and region-specific removal timing, both of which appear in clinical vignette questions. The fundamental rule of suturing is approximate, do not strangulate. The purpose of a suture is to bring wound edges into contact, allowing healing to occur. It is not to compress the tissue. Excessively tight sutures create local tissue ischemia by compressing the microvasculature, paradoxically impairing the very healing process they are meant to support. This causes the characteristic suture track marks and increases the risk of wound infection and dehiscence. For material selection, absorbable sutures, such as polyglycolic acid or polyglactin, are used for deep tissue layers, including fascia, muscle, and subcutaneous tissue, where they provide temporary tensile support while the wound develops its own strength, then dissolve. Non-absorbable sutures, such as nylon or polypropylene, are used for skin closure and must be removed when the wound has developed sufficient strength. Removal timing is body region specific and directly reflects the local blood supply and mechanical tension on the wound. Facial wounds are removed at 5 to 7 days. Rapid healing driven by the exceptional blood supply of the face, combined with cosmetic priority to minimize suture track scarring. Scalp, trunk, and upper limb wounds are removed at 7 to 10 days. Lower limb, back, and joint wounds are removed at 10 to 14 days, reflecting the slower healing, poor blood supply relative to the face, and the high mechanical tension placed on these regions during movement.
Step 5 in the framework requires anticipating the factors that will prevent healing, because identifying and correcting these factors is as important as the technical closure itself. Complications of wound healing fall into 2 categories: systemic roadblocks that affect the entire patient, and local roadblocks specific to the wound environment. Systemically, age is a significant factor. Elderly patients exist in a relative catabolic state, with reduced cellular turnover, slower inflammatory response, and diminished fibroblast proliferation. Malnutrition is perhaps the most correctable systemic factor. Protein deficiency limits the raw material for collagen synthesis. Vitamin C deficiency, as we covered, prevents collagen hydroxylation. Zinc deficiency impairs metalloprotease activity required for wound remodeling. Metabolic and immunological disease creates a profound impairment. Uncontrolled diabetes mellitus impairs neutrophil chemotaxis and phagocytosis, delays the inflammatory phase, and creates microvascular insufficiency, reducing local oxygen delivery. HIV and other immunosuppressive conditions reduce the macrophage and lymphocyte populations essential for wound orchestration. Prolonged corticosteroid use, one of the most tested pharmacological causes, suppresses all phases of wound healing, particularly the inflammatory and proliferative phases, while also causing skin fragility that increases wound breakdown risk. Smoking causes nicotine-induced vasoconstriction, producing severe local tissue hypoxia. Locally, infection introduces bacterial proteases that actively degrade newly synthesized collagen as fast as it is produced. Mechanical stress and edema compress microvessels, reducing perfusion. Devitalized or necrotic tissue acts as an infectious nidus that must be removed by debridement. Local hypoxia blocks both collagen hydroxylation and the neutrophil oxidative burst required for bacterial killing.
The diabetic foot ulcer is the ultimate clinical synthesis of everything covered in wound healing, and it is one of the most commonly tested chronic wound scenarios on board examinations worldwide. It demonstrates how multiple simultaneous pathological processes converge to create a wound that the body is biologically incapable of healing without external intervention. 3 distinct mechanisms operate in parallel. The first is hyperglycemia. Chronic elevation of blood glucose directly impairs neutrophil chemotaxis, the ability of neutrophils to migrate toward infected tissue. It also impairs phagocytosis, the ability to engulf and destroy bacteria. The resulting delay in the inflammatory phase means the wound spends too long in an unresolved inflammatory state, increasing infection risk and preventing progression to proliferation. The second mechanism is peripheral neuropathy, damage to sensory nerves that deprives the patient of protective sensation.
Without the ability to feel pain, heat, or pressure, patients sustain repeated, unrecognized mechanical trauma to the foot during normal walking and daily activity. Small injuries accumulate without being noticed or treated, eventually breaking down skin integrity entirely. This is why diabetic foot examination and protective footwear are not optional. They are life-saving interventions. The third mechanism is microvascular disease, progressive narrowing and occlusion of small arteries and capillaries in the extremities. This reduces local oxygen delivery, directly crippling the angiogenic response required to build new granulation tissue and simultaneously limiting the oxygen substrates required for collagen hydroxylation and neutrophil bactericidal function. The conclusion boards expect you to state: diabetic wound pathology is the ultimate convergence of impaired immune function, repeated mechanical injury, and chronic local hypoxia, all three operating simultaneously.
When wound healing overshoots its normal endpoint, pathologic scarring occurs. Understanding the two types of pathologic scars and their distinguishing features is a consistent examination topic. Both represent excessive collagen deposition beyond what is needed for structural repair, but they differ in behavior and extent. A hypertrophic scar is confined within the original wound boundaries. It does not extend beyond the margins of the initial injury. Importantly, hypertrophic scars tend to regress spontaneously over time with conservative management, and they are not strongly associated with specific skin pigmentation types. By contrast, a keloid scar extends aggressively beyond the original wound margins into surrounding normal skin. This is the defining characteristic that distinguishes it from a hypertrophic scar. Keloids do not regress without treatment and have a high rate of recurrence even after surgical excision. They occur with higher frequency in patients with darker skin pigmentation and at specific anatomical sites, including the earlobes, sternum, and deltoid region. Treatment includes intralesional corticosteroid injections, silicone dressings, radiotherapy, and surgical excision with immediate postoperative steroid injection to reduce recurrence. Now, for the critical alert: fascial dehiscence. This is the separation of the abdominal fascial closure layers distinct from superficial wound breakdown. The pathognomonic clinical sign is serosanguinous, salmon-colored, fluid draining from the wound in the postoperative period, typically between days 5 and 10. This drainage represents peritoneal fluid escaping through the failing fascial closure. When this sign is identified, urgent surgical evaluation is mandatory, because the next progression is evisceration, where bowel protrudes through the wound, a surgical emergency requiring immediate return to theater.
The sixth and final step in the wound management framework is deploying the appropriate therapeutic adjuncts. 4 key therapies must be understood in terms of mechanism, indication, and board relevance. Negative pressure wound therapy, abbreviated NPWT, and also known as vacuum-assisted closure, or VAC therapy, applies subatmospheric pressure, typically negative 125 millimeters of mercury, to the wound surface via a sealed foam dressing connected to a vacuum pump. The mechanism is multifaceted. It mechanically promotes granulation tissue formation by stretching fibroblasts, reduces local edema by drawing fluid away from the wound, removes bioburden and wound exudate, and draws wound edges toward one another. NPWT is indicated for large open wounds, diabetic foot ulcers, pressure ulcers, and as a bridge to formal closure. Hyperbaric oxygen therapy delivers 100% oxygen at pressures of 2 to 3 atmospheres in a sealed chamber. This dramatically increases dissolved oxygen in plasma and tissue, directly supporting 2 oxygen-dependent processes: collagen hydroxylation and the neutrophil oxidative burst. HBO is indicated for radiation-injured wounds, chronic hypoxic wounds, gas gangrene, and refractory diabetic foot ulcers. Antibiotic stewardship in wound care must be tied to the surgical risk classification. Clean wounds rarely require prophylactic antibiotics. Clean contaminated wounds receive a single preoperative dose of a narrow-spectrum agent. Contaminated and dirty wounds require therapeutic antibiotics with extended courses. Tetanus prophylaxis must be assessed in all puncture wounds, avulsion injuries, and grossly contaminated wounds.
The decision to administer tetanus toxoid versus tetanus immunoglobulin depends on the wound's classification as clean minor versus all other, combined with the patient's documented immunization history.
We close with the most efficient exam revision tool in wound care, the complete numeric cheat sheet. Every number on this list has appeared on board examinations and must be committed to memory in exact form. 18 hours, the minimum age of a yellow bruise, determined by the biochemical conversion of biliverdin to bilirubin through hemoglobin degradation. A yellow bruise cannot be less than 18 hours old. This is forensically significant and clinically tested. 24 hours, the time to peak polymorphonuclear neutrophil infiltration in a fresh wound. 48 hours, the time to peak macrophage infiltration, marking the transition from inflammatory to proliferative healing. 24 to 48 hours, the time to complete epithelialization under primary closure, which is also the safe window for removing the initial occlusive dressing. 1 millimeter per day, the precise rate of epithelialization in secondary intention wounds, advancing from the wound edges inward. This number is tested in questions asking about wound tracking and expected healing timelines. 3 months, the time to reach maximum wound tensile strength. This plateau represents the end of the remodeling phase. 70 to 80%, the maximum tensile strength a healed wound ever achieves relative to native uninjured tissue, never 100%. The wound classification infection risks: 2% for clean, 5% for clean contaminated, 15% for contaminated, and 35% for dirty or infected. Print this list. Recite it. These numbers are the difference between a good score and an outstanding one. This is Studious. Please like, comment, share, and subscribe for more high-yield clinical content.